I don't think there's that much extra to be said about myself. I'm very privileged to be here. Thank you again to CANSA for the kind invitation, and then certainly for arranging such an esteemed audience for me. Thank you very much. My talk is then about optimal prevention for cervical cancer in South Africa. This is an extremely wide talk. It's almost impossible to cover all the aspects. I have been very outspoken about different aspects of optimal prevention for cervical cancer in South Africa at many forums in our country, talking about vaccination, talking about specific aspects of screening, etc. Today, I rather would like to talk a little bit more about combining these approaches and about the fact that we really need to address all the issues, and we can't only focus on one of the issues or on either one of the prevention things. This picture of Africa and of Southern Africa, Sub-Saharan Africa, being very red there on the map, is very well known. This kind of map is shown at every cervical cancer talk in the world, and certainly in Africa. We don't know exactly what the incidence of cervical cancer in South Africa is. It depends on which source you use. We know that it is far too high. We know that it is in all probability above 30 per 100,000. It is hopefully under 80. The most commonly quoted figures today is between 30 and 40 as an estimated case numbers per 100,000, but it is far too high. And also, in addition to that, women in South Africa die of cervical cancer. While your chance to die from breast cancer, if you get it in South Africa, is at most 50%, your chance to die from cervical cancer is much more than that. If you're diagnosed with cervical cancer in South Africa, your chance to die from that disease is far more than 2/3. So it is a very, very important health issue, and certainly in women's circles. So I've talked a little bit about the incidence, which is too high. The national screening policy is being implemented. It's not unimplemented, but it is not optimally implemented, and we all know that. More than 60% of women actually present late. We've done some work on who is to blame. Is it the woman who just presents late, who is not well informed about the disease, or is it actually the health facilities who fail the patient? And in one of our studies, we actually showed a mean number of 7 visits to healthcare facilities before a histological diagnosis of cervical cancer is made. So we can in no way blame this to the patient. It is the health system which is failing the patient. And there is a huge problem with knowledge about the diagnosis of this disease, the way it presents, and actually responding to the woman who does complain. And that makes our survival rate so low. So the proposal that I want to present a little bit today and this morning is in a combined approach. I would like to actually say that we should continue cytological screening, and I'll give you my reasons for this. I want to say that we absolutely have to develop molecular screening, and I'll also debate that a little bit and tell you why I think so. We need to also build the capacity in this country to screen and treat, hopefully at 1 visit or at less than 3 visits, at most at 2 visits, because patients do not have the ability or the push or the reason to come back for repeated visits for a disease which they do not experience. We have to treat them at most, in my opinion, at the very first visit after we have them back after screening, preferably same visit. Of course, we all agree that we have to implement vaccination, that there's really no debate about it, and I'll tell you a little bit of my thoughts about how we should possibly go about doing that in our country. And then we do have a problem treating invasive cancer cases. Many of our tertiary institutions have long waiting times, 6 weeks, 3 months waiting times for surgical lists, and the radiotherapy lists often have much longer waiting time. So if we start screening more, if we start detecting more disease, we actually see a big increase in the problem that we create for ourselves, namely seeing patients and diagnosing patients which we then actually struggle to treat. So we need to focus on that aspect as well. The background to this whole debate has been very well shown and illustrated by Professor Williamson, really with the HPV cell going into the life cycle of the cervix, changing the cells into abnormal cells, over time more and more abnormal, shedding virus to the environment, men and women will shed it. And then in the end the cells actually grow through the basal layer and then becomes an invasive cervical cancer. So bearing that in mind, how should we screen for this disease? My reasons for actually supporting ongoing cytological screening is that we have so little capacity in this country. We cannot possibly consider stopping to use our existing capacity. We can't stop using the cytologists. They are there, they are good, they are doing a fantastic job. We have sisters in the clinics who know about cytology, who actually do their job well, and this is very different in different regions in our countries. And where in a region this system is working well, we can't possibly consider killing it. We will do a lot of harm. So we must continue to actually support cytological screening and offer this as one possibility to screen women who present themselves, or maybe we'll get to the point where we actually call them out of the community to have screening. There's also a lot of personal investment in this, and there are a lot of people who have spent a lifetime looking at cytology. Now, this is not a strong argument, but there's actually no reason not to do this, and we will forever need cytologists. We'll need them to support the HPV program. We'll need them for many things, cytological diagnosis, breast cancer, etc. So we really need to support these people in this program. We haven't talked about the South African HPV Advisory Board a lot. This flow diagram was developed by that board. It's not a very unknown type of flow diagram. It starts with cytology. It indicates where HPV screening can actually be implemented into the cytology primary screening program, but it then is one option to screen people starting with cytology. And I don't think it will go away. It's going to be with us for a long time. But if we look at the best predictor of cancer, we have to say that it is actually detecting the virus and detecting the fact that the virus is there, and especially high-risk viruses, and especially HPV-16. It's now well understood throughout the world that your chance to be diagnosed with a high-grade lesion or with cervical cancer is actually better predicted by showing that you are harboring persistent high-risk virus than by any other means. And this is a better predictor actually than cytology. The problem with cytology being that the once-off cytological examination has a low sensitivity and a chance of about 50% of missing an existing lesion, while the HPV test is erring on the other side by being oversensitive.